I want to introduce to you Dr. Burke. I've known Dr. Burke a long time. Wiley, it's such a pleasure to have you here tonight. She is professor and chair of the Department of Medical History and Ethics of the School of Medicine, as well as adjunct professor in epidemiology at the University of Washington. She received her PhD in genetics and an MD from the University of Washington, and she completed postgraduate training in medical genetics also at the University of Washington. She's received the NIH Advisory Council, served on the NIH Advisory Council for Human Genome Research and the Secretary's Advisory Committee on Genetic Testing, and is currently a member of the National Research Council Committee addressing the predictive use of toxicogenomics technologies. I almost got that out with that. Dr. Burke is a faculty member in the Public Health Genetics Program and in the Medical Genetics Training Program. And in 1994, she became the founding director of the Women's Health Care Center at the University of Washington Medical Center, which is up on Roosevelt. And she served in that role until 1991. She has also previously served as Associate Director of the Internal Medicine Residency Program. So will you please welcome tonight Dr. Wiley Burke.
Thanks very much. It's a real pleasure to be here. And I'm very happy to be here to have the opportunity to be here to talk with you about this topic of personalized or individualized medicine. In the area of medical practice where I work in medical genetics, this is a very exciting time. And what I'm going to talk with you about is what we can do now as a result of the advances in research that have occurred over the last 10, 15 years, and then give you a little bit of a picture of where I hope we'll get to, because we're still just in the very beginning of using genetic information to help us personalize and individualize care, particularly for cancer. So what I'm going to talk about in these initial remarks is how we are currently using genetic information in order to do better with respect both to cancer prevention and cancer management. What we're able to do is to use family history information, which is a form of genetic information, and also increasingly genetic testing. Genetic testing being a circumstance where we take a blood draw, a normal regular tube of blood, and then the laboratory procedures involved measure specific changes in DNA, that is in the genetic material, to determine whether or not a genetic susceptibility to a particular cancer is present. And I'm going to give you some examples of that. The purpose of identifying genetic susceptibility in the setting of cancer is in order to identify people who would benefit from specific measures that we don't offer to people of average risk, and thereby we improve their care. Let me start with the simple, family history. Right now, we're able to use family history information to improve our decision-making about colon cancer screening. We recommend colon cancer screening to everyone, but the particular recommendations that we make depend on a person's family history. If you have no family history of colon cancer in your family, your risk to have colon cancer is 4%. That's the average risk in the US population. If you have one first-degree relative, a first-degree relative is the person closest to you in your family, so it's a parent, a brother or sister, or a child. If you have one first-degree relative with colon cancer, your risk is more than doubles. Your lifetime risk becomes 9% instead of 4%. Your risk also kicks in at a younger age, so that people who have a first-degree relative with colon cancer have the same risk at age 40 that the person with no family history has at age 50. And that becomes very important in how we do colon cancer screening. If you have two or more first-degree relatives, on average, your risk rises to 15%. It's actually a little bit more complicated than that. When we step back and look at family histories of colon cancer, what we see is there's a whole spectrum. And one of the things that's happening in genetics right now is that we're trying to understand with increasing precision what the risk is along that spectrum. If you look, for example, in the slides that are in front of you, the slide on your left, on the far left, is a family in which there's a grandfather. The boxes represent men and the circles represent women. So what we have is a grandfather who had colon cancer at age 80. his grandchildren actually don't have an increased risk relative to average. That's not a very significant family history because it's in a grandparent and because cancer occurred at age 80. In the middle, we have we have a situation in which a mother has colon cancer at age 60, and her children have a significantly increased risk of colon cancer, doubled or a little bit more than doubled compared to average. But then over on the far right, we have a very unusual family history. I think you can see that this is not the kind of family that we see very often. This is a family in which there's a grandfather who had colon cancer at age 48, a very young age. His daughter had colon cancer at age 54, also young, and a grandson has had colon cancer diagnosed at age 42. We're seeing the cancer going through sequential generations and occurring at a very young age. These are extremely rare families. They probably don't occur more often than 1 in 600 in the population, and these people represent very high risk. How do we respond? Well, we make different screening recommendations. We recommend that everyone start colon cancer screening at age 50. If a person has a first-degree relative, like that middle family, mom had colon cancer at age 60, we're going to recommend starting screening at age 40 instead of 50. The risk is higher, and the risk starts a little younger. If we see a family like that, very high-risk family, we actually start screening at 20 or even earlier. And in some cases, we're able to use genetic testing to further evaluate people in those families. So that's just an example of how we can use even something as simple as family history to begin to sort out what are the right kinds of cancer prevention strategies to use. I'm going to go through a few examples, and here's another example which shows how powerful genetic testing can be as a tool to provide very specific cancer prevention benefits. This is a family in which there's a very rare disorder called familial medullary thyroid cancer. Medullary thyroid cancer is an unusual kind of thyroid cancer. It accounts for less than 10% of thyroid cancer overall, and it's very hard to treat. The mortality is much higher than from the usual kind of thyroid cancer. And about 25% of the time, this particular unusual cancer occurs in a familial form. You can see a pattern that's a bit like that high-risk colon cancer. What we have is a man who's recently been diagnosed with familial medullary thyroid cancer, and his father died. The diagonal line through the box indicates a death. His father died of familial medullary thyroid cancer, and because we've got these two family members, we can now begin to predict that this is an inherited form of medullary thyroid cancer. So we know, because of the pattern of inheritance, that this dad, who's just been diagnosed, has a 50-50 chance with each child of passing on that high risk for a very severe form of medullary thyroid cancer. Until about 5 years ago, that's all we could do, is we could tell people about this inheritance pattern. And we could do screening, we could watch people carefully and try and treat the thyroid quickly, the thyroid cancer quickly when it occurred. What we now have is a testing opportunity that allows us to take preventive action. It turns out that familial medullary thyroid cancer, the inherited form, is caused by mutations in a gene called the RET gene. When there are particular mutations or changes in the RET gene, the result of it is this predisposition. In fact, it's a very powerful predisposition. People who have RET mutations associated with medullary thyroid cancer have a virtually 100% lifetime risk of developing cancer. So when the dad is diagnosed with medullary cancer, what we now do is we have him undergo genetic testing. That genetic testing isn't going to change the care of his cancer. His cancer is still going to be treated based on the best cancer care we have for medullary thyroid cancer. But if we can identify the mutation that's causing his cancer, we have a test to offer his children. Each of the children has a 50-50 chance of inheriting the cancer predisposition. We can determine with a test which child inherited and which child didn't inherit. And the current standard of care in this rare inherited disorder is to offer prophylactic thyroidectomy, preventive removal of the thyroid gland, to children who've inherited this cancer predisposition. This is a strategy that's been used really only for 4 or 5 years. We have that much follow-up. But based on the 4 to 5 years follow-up that we have very good indicators that the risk of cancer is dramatically reduced, as you would expect. So this is a way in which we can move beyond looking at family predisposition and predicting who's at risk to actually using genetic information to do something specific and preventive. Now I want to talk about breast cancer, because breast cancer is probably the most talked about example of using genetic testing to identify cancer predisposition. Exactly as we have with the high-risk colon cancer family that I showed you and with the thyroid cancer family that I showed you, we have families who seem to have a very high risk of breast cancer. And I'm showing you a family here. What we have is breast cancer in a grandmother, in a mother who died in her 40s, and there's a sister who's recently been diagnosed with breast cancer at 38. These families, again, are not common. The estimated prevalence is somewhere between perhaps 1 in 500, 1 in 1,000. These are families in which there's a very high risk of breast cancer. Breast cancer occurs at a young age. And most of these families also have, as part of the cancer predisposition, a very high risk of ovarian cancer. There may be other cancers associated. Increasingly, we see data that suggests that other cancers may also be associated. Pancreatic, for example, is seen in some of these families. And we're still really in the active stage of understanding all of the implications. But what we know for sure is that we can identify families like this, and as with the other examples, we can identify people who are at increased risk. The arrow is pointing to the person who's often most concerned at this point. Her sister's been diagnosed with breast cancer at age 38. Her mom died of it when she was pretty young. Her grandmother died young enough that she never really knew her grandmother. So this is a very significant burden in the family. And she wants to know what to do about it. This is something that a research subject said to me, a research subject who had been found to have a BRCA1 mutation, because study of families like this has identified 2 genes, BRCA1 and BRCA2, like the Rett gene. These are genes where a mutation, a change in the gene, causes a cancer susceptibility. I watched my sister go through chemotherapy and radiation, and it was terrible. I can't sit and wait for that to happen to me. So we now have the ability to use genetic testing to identify risk in families like the one I've just shown you. And the critical question, just as with the prophylactic removal of the thyroid, the critical question is, what can we do for that sister who has a high risk of breast cancer to prevent her from developing breast cancer? Well, this is where the story gets very complicated in terms of where we are right now, because the main thing we can do, the most definitive thing we can do for women in this situation, is to offer them a prophylactic mastectomy, that is preventive removal of the breasts. And it works. Here's a study, it's just a very simple study in which women who were known to have a BRCA1 or a BRCA2 mutation were offered prophylactic mastectomy, and some accepted that offer and some did not. And what they found over a 5-year period was that the women who had prophylactic thyroid mastectomy didn't get breast cancer. And the women who didn't have the surgery had a significant number of breast cancers, as we would expect, because we knew them to be at increased risk. So this is a surgery that works just like the preventive removal of the thyroid does. But, and again, I think this may not be surprising, most women at risk don't choose this surgery. So what we're showing here is summary data from 4 different studies. And these studies have looked at what women decided to do after they were told that they were at high risk. And some were told that they were at high risk based on their family history before we had genetic testing. And others were told that they were at high risk based on genetic testing after genetic testing became available. And what you can see is that overall, only a minority of women who've been told about their high-risk situation and offered preventive removal of breasts have chosen it. So this ranges in these studies between 0% of women and about 17% of women. And again, I don't think I need to elaborate. This is not really a surgery that women welcome. It's not a preventive measure that women welcome. I've worked with a medical anthropologist to talk to women to understand what's the thinking that they bring to this option and to clarify in some detail the reasons why this is not acceptable. And what we found when you talk to women about this as a prevention option is that in some senses it just doesn't make sense to women to take such a drastic step in order to prevent cancer. No, I would only do it to save my life. It seems stupid to do that because you don't even have to have a full removal of the breast with a lot of breast cancer. So why would I do that as a preventive? That would be like chopping off a finger because you're afraid it might get broken someday. In fact, what we think is that women are not eager to take on the illness before they have the disease, which I think is very understandable. What was also interesting in our interviews is that many women questioned whether docs should even offer this option. I'd want a second opinion. I'd want 2 or 3 different opinions. I would change doctors. I would be thinking the man is a quack. All of which are actually very important data, I think, to say that while it's appropriate to offer women this option when they're at high risk, it is very appropriate to offer it and not recommend it. This is a choice that should remain a personal choice with the woman at risk. Well, what else can we do? Increasingly, we're interested in trying to sort out how much benefit we can offer from breast cancer screening. There are 3 different kinds of screening strategies that we use, and I'm going to show you a little bit of data on these for high-risk women. We use clinician breast exam. We use early mammography because women from these high-risk families, as you saw, can get breast cancer as early as the early 40s. We typically start mammography screening between 25 and 30. And now, recently, we have the opportunity of a technique called MRI, or magnetic resonance imaging, a much more sensitive radiologic technique that we hope will offer some additional benefit. There aren't a lot of other options. Women at increased risk can use tamoxifen, which is a chemoprevention agent used in breast cancer. It's been shown to have some preventive benefit, although in the women at particularly high risk, particularly women with mutations in the BRCA1 gene, there's a lot of uncertainty about whether it actually works. And then because women are at increased risk for ovarian cancer as well, we can offer surgical removal of the ovaries. None of these options represents the magic bullet that we would like to have, the truly safe, simple, effective prevention therapy. And I think that's part of the complexity. As we're able to identify increased risk, we want to be able to do something about it. And at this stage, our ability to identify risk sometimes outpaces our ability to do things for it, or to do the kinds of things that we'd like to. Now, let me talk about breast cancer screening just to show you some of the complexities that we get into. When you're doing screening, doing something like a mammogram or an MRI to find early breast cancer, that's what the purpose of screening is. We know that if we can find cancer early, we can usually treat it very effectively. In the case of breast cancer, we have a very good chance of cure if we can find breast cancer early. So we want to use screening techniques to do that. We have to be concerned about issues of sensitivity, which means with this test, how many people with cancer are going to be identified? How good is this test at finding people who have cancer? And those are, of course, the true positives, the people who have cancer and have a positive test result. And you can tell from that terminology that we need to be worried about false positives, because screening tests will find things where there isn't a cancer. They'll find an abnormality that we have to worry about and then turns out not to be cancer. We also have to worry about false negatives. We have to worry about the person who has cancer but doesn't show up on the test. And another property of a test that we have to be concerned about is specificity. What proportion of people with a negative test really are without cancer? Those, of course, are the true negatives. But as we've already mentioned, we have to be worried about the false negatives as well, the people that have cancer but get a negative test result. And also with screening, we have to worry about the cost and discomfort and risk of screening. So, as I mentioned, in high-risk women, what we currently have is the opportunity to do clinician breast exam, CBE on this diagram, mammography, and MRI. And the slide here, the data shown on this slide, explains to you why people are getting very interested in MRI as a strategy for screening high-risk women. Look at the yellow bars, which show sensitivity. Sensitivity is how many people with an early cancer do we find with this test. And you can see that MRI is much more sensitive than any other screening technique that we have. And that's a good thing. It's also less specific. The difference in the blue bars isn't as dramatic. Most of the people who have a negative test don't have cancer with all of these screening tests. But that proportion is smaller. That proportion is smaller with MRI. MRI is a less specific strategy. Okay, how does MRI do finding early cancer? Very well. So in fact, if we want to find small tumors, tumors that are smaller, that are either 10 millimeters or 1 centimeter in size or smaller, we can see that MRI does that a lot better than the other strategy. So it's more sensitive and it can find smaller tumors. Again, this looks like a good thing. Now, just to summarize another piece of the MRI story, when you get an MRI result, it's categorized according to highly suspicious. This lesion really looks like it's cancer. Suspicious, might be cancer, might not, and uncertain. And you can see that when you look at MRI results across those different categories, you see different rates of true positives, false positives, and women having to undergo biopsies. When you have a highly suggestive finding, the true positive rate is very high. There are some false positives. There are biopsies that turn out to be nothing. But much less so than when you have a lesion that's an abnormality that's labeled suspicious, and the false positives get very high when you have a radiology result that says uncertain. So, what do we think about MRI? Well, we think that MRI is a much better technique than mammography for finding early cancer in high-risk women. And we're extremely interested in using this technique. In fact, the current standard of care for women who have BRCA1, BRCA2 mutations, but don't wish to proceed to a preventive removal of the breast, is to have women screen with mammography and MRI alternating every 6 months. So mammography once a year, MRI once a year, but a screening test every 6 months. But the reality is that we have a very tough decision to make in terms of who we offer that screening strategy to in two ways. One is everyone who has MRI screening has a much higher risk over their lifetime of having many false positive results that will result in their going through biopsy procedures, which in themselves are very burdensome. So that's part of the cost of MRI. It's a certain amount of anxiety and personal discomfort. And even more significantly, MRI is very expensive. So an MRI screening ballpark estimate screening cost would be about $1,000 as compared to a mammography cost of about $100 or less than $100. So it's a very dramatic cost differential. And one of the things we have to really struggle with is who do we offer this screening strategy to, and when basically are the burdens of multiple biopsies and of the cost of the procedure worth it in terms of the risk that the person faces. Let me get back to another issue with family history of breast cancer, and that is the complicated issue of how risk gets discussed or addressed through the family. I showed you this family earlier, and what I said was that the sister is the one who's really concerned. Her sister had breast cancer at age 38. She's now getting her chemotherapy and radiation therapy. There's a very strong family history. The sister is interested in what her options are. She's very interested in learning about her screening options, for example. Maybe she'll be interested in talking about prophylactic mastectomy. What we have to do to give her more definitive information about her risk is we need to do genetic testing. But there are hundreds and hundreds of different mutations in the BRCA1 and BRCA2 genes. So the right way to do testing is to start by testing an affected family member, which means her sister needs to undergo testing first. Her sister may not want to think about this right now. She may be in the middle of her cancer treatment, and she may be uneasy about thinking about this, or she may be willing. But it's a family communication issue that has to be addressed. Once the sister is tested, if we find a mutation, then we have a very good test to offer her sister to determine whether or not she inherited that cancer predisposition. About a third of the time in families like this, we can't identify the specific mutation. And we think that's because our current testing technology can't identify all BRCA1 and BRCA2 mutations, and also because there are other genes that we think are yet to be found that account for some high-risk families. So there's a complex family counseling issue that we need to go through as we work through the genetic testing options. And one of the things that can happen is what's diagrammed here. If you have a sister who wants genetic testing, and another sister who doesn't want genetic testing, the family has to decide ahead of time how they're going to manage that information, how they're going to talk within the family or make agreements not to talk within the family, because not everybody wants this information. Again, a personal and often very charged and emotional decision. Why would people not want genetic information? Well, there certainly are concerns about knowing about genetic risk, and those concerns may be greater if you've decided there's nothing you're going to do differently. If already, based on your family history, you're going to go through an intensive screening program, you know you don't want a prophylactic mastectomy, perhaps the risks of genetic testing aren't worth the benefits. What are the risks? Well, we certainly worry about discrimination, and I'll talk with you a bit about what that constitutes. We worry about stigmatization, people feeling differently about themselves or others feeling differently about them because they're known to have a genetic risk. And we worry about unnecessary or unproven therapy. When you find a risk, you have a tremendous motivation, and your physicians have a tremendous motivation to do things. And that includes doing things that we feel might work, but we may not yet have the evidence to know for sure if they work. So there is a risk to finding genetic risk information when we're not sure exactly what the prevention options are. We worry a lot about genetic discrimination. I think there's a consensus in this society that what's wrong, that the wrong thing to do with genetic information would be to deny anyone access to health insurance based on whether or not they have a BRCA1 or BRCA2 mutation. Many states have passed anti-genetic discrimination legislation to prevent this. State of Washington doesn't have such legislation, but what state of Washington does have is very strict limitations on the information, the medical information that can be used by insurance companies in pre-existing conditions, probably offering an analogous benefit to anti-discrimination laws directed toward genetic information. But this is clearly a concern, and depending upon where you live and how you get your insurance, whether you get it through a group, a large group, or whether you pay for it personally, this could be a very important concern to people. There's another issue that I think has to do with a broader societal problem, and that is when we have families that have a cancer predisposition, we have a great interest in offering them the best prevention options, the best screening options, and the best testing options that we can. But access to genetic services, for example, the access to the opportunity to have BRCA1/2 testing, which costs about $3,000, by the way, is also very expensive. And access to a genetic counselor, access to coverage for the service, whether or not the insurance will pay for it, are very significant concerns. My colleagues and I who do cancer genetics at the University of Washington, for example, have a lot of concern about the limited access of low-income King County women to genetic counseling and to genetic testing, which is generally not covered by public insurance companies. the same kinds of opportunities and difficulties in determining what to do with the information and when it's useful are emerging in a variety of other cancers. As I've mentioned, breast cancer families also include a risk for ovarian cancer. Increasingly, we're seeing families and specific genetic variants associated with risk of uterine cancer, which sometimes links with colon cancer. There are some families at high risk for stomach cancer, and we actually have a genetic test to identify those families. We now have a genetic test to identify rare families with a high risk of melanoma, and we have very active research identifying genetic factors that contribute to prostate and pancreatic cancer, and I think this is just the beginning. We're clearly entering an era of genetic testing. And we're going to have a lot of questions as we have increasing cancer genetic information. When does the harm of a genetic label outweigh its benefit? How do we think about that? Well, clearly we have to think about what are the benefits. You know, what do we have to offer as a result of this information? And hopefully the benefits we have to offer increase in power, making the benefits much more important than the label. But the issue of labeling with risk is important. When and how should genetic tests and services be offered? What kind of genetic counseling do people need in order to make what are often very highly personal decisions? And how can we assist people work through the complex family communication issues that may be needed? How do we ensure access to all who would be candidates for testing, I think is a great concern. And as we approach these issues as health policy concerns, there's clearly the general issue of who should be involved in that decision and what kind of criteria should we be using. So I'm going to stop there, and I'll turn it over to Terry.
Our next guest tonight is Dr. Benjamin Greer. Dr. Greer earned his MD at the University of Pennsylvania School of Medicine, and he completed his residency at the University of Colorado Medical Center. He's the director of gynecologic oncology in our own Seattle Cancer Care Alliance. Dr. Greer coordinates a team of specialists to provide care to women with gynecologic cancers. His work has included groundbreaking research, authoring textbook chapters, some of which I've read, editing 2 books, caring for patients, mentoring younger physicians, and participating on innumerable boards and committees. And his research with colleague Dr. Weijin Ko, and Weijin and I were interns together, so I think fondly when I hear about Weijin. UW professor of radiation oncology changed the way radiation therapy is given to women with gynecologic cancers. So please welcome Dr. Benjamin Greer.
Do you want to make a few remarks first, or are we just going to go over?
It's a pleasure to be here. Our forum will be a little bit different, I think, than some of the traditional things, and Dr. Burke and I will have a conversation about what it is to have individualized treatments and what the impact of screening and how that is dealt with on a personal basis.
Well, thank you very much. I want to start our conversation by asking you to explain how you first became aware that cancer was an issue in your family.
I think when I was about 9 or 10 years old, my grandmother on my mother's side died of breast cancer. And when I was a medical student, my freshman year, my father was diagnosed with pancreatic cancer and died 3 months to the day after his diagnosis, which happened to be the day after my last exam. So I became very sensitive about that. And when I was a junior in medical school, my mother had a colon cancer at age 54. And then as I went through my medical education, that colon risk was higher. And then within my own disease set, ovarian endometrial, fall into that. So I'm very, very much attuned to it. And being interested in my own health, my gastroenterologist had screening colonoscopies. And I asked him, I said, gee, my father died of pancreatic cancer, am I at risk? And he said, no. A single-member family doesn't really put you at a higher risk. And about 2 years ago, my brother called me one day and said, gee, by the way, I'd let you know that I have pancreatic cancer. And I let my gastroenterologist know, and from that it was we need to get some testing and figure out if I'm at risk based on the information we have.
So there was a dramatic moment when when the additional affected member in your family made it clear that there was a familial pattern.
Yeah, in the gastroenterology department here, Dr. Brentnall is very interested in pancreatic family histories and have developed a program to evaluate and to make recommendations depending upon what the risk factors are.
So your brother was diagnosed with pancreatic cancer. That was kind of an indicator that this was an important issue for you. And fortunately, there's research going on here, researchers that are particularly interested. What happened next in terms of evaluating you?
Well, I mean, I feel very fortunate that this is one of the few centers in the country that have taken a more proactive approach to pancreatic cancer and rely on other means of trying to evaluate and examine patients. So I went through a series of testing. First, they did a transesophageal ultrasound of my pancreas, where they drop an ultrasound probe and look at the pancreas, look at what the characteristics are. And then I had an ERCP, which is where they put a scope down, put a little tube in the duct that comes out of the head of the pancreas and squirt dye in there and look at it and see if it has suggestions of a pre-malignant pancreatic condition. And my study demonstrated that I had probably was at high risk to be in that category. And following the tests, we had a meeting and conversation with the gastroenterologist, Dr. Brentnall, my surgeon who did my surgery, myself, my wife, to make a decision. And that the recommendation was that I have exploratory surgery, at least a partial pancreatectomy and possibly a total pancreatectomy. And I was in somewhat of a dilemma because I had a national presentation to do about 6 weeks after the proposed surgery date, and I thought about it. I thought, well, I don't want to be sorry, so I went ahead and took it, and I told my surgeon I will be there to give my presentation, which I did. Attitude means a lot.
So we should just go over that again. I think Dr. Greer just told us that he, 6 weeks after this fairly major surgery, was able to do his national presentation.
Yeah.
This has to have been a pretty tough time for you.
Well, you know, it's not every day in your life you get a chance to duck a lethal bullet. And having seen my dad die as he did and have other people that I know, one within our institution that died very quickly of pancreatic cancer. In my diseases, ovarian cancer is usually the one that is problematic, and we see about 26,000 cases, and we have about 17 or 18,000 deaths in that group. So it's we call it kind of a high risk. And although I knew pancreatic cancer had bad stats, I went and looked up at the American Cancer Society, and there's 30,000 cases and 300 survivors. And it makes your decision pretty easy when you look at those kind of numbers.
But at the same time, a pancreatectomy is not an insignificant surgery. I mean, this must have had a big impact on your life.
Well, as we all mature, there's certain things you have to do to keep going. And so I took that approach to this, that without your pancreas, you have two issues. One, you have no insulin, and two, you don't have very good absorptive capacity because you don't have the pancreatic enzymes. And with insulin and pancrease tablets, which you take with your meals, life is good.
To what extent do you think having the medical training before having all the medical experience and training that you had before you faced this decision helped you to think it through? Do you think that was helpful to you?
Well, I think that it was very helpful in that dealing with kind of life and death situations within my own group and practice as a tertiary center, we're kind of faced with this all the time. And also, I have a kind of a philosophy that I don't like to lose, and so that if, to kind of take the win-win strategy is that the trade-off between having the surgery, which could, since that was an accident waiting to happen, that, yes, I had to have surgery. There was ways to manage the downside of what is a result of that and be able to live a healthy and productive life, which I continue to do.
Mm-hmm. Any last comments that you want to make?
Well, I think that it's important, I think, as people reflect on their own histories and some of the things that Dr. Burke gave in terms of the genetic things. Our joint effort between the Hutchinson and UW Medicine in trying to do prevention and early detection is that these should be problems that we should be able to solve. And I hope by the time that my children get of age to be at risk that we will be able to do some kind of genetic testing or something that would provide an answer to, just as you pointed out with some of the diseases that you spoke about, to make good decisions to have good outcomes.
Mm-hmm.